Well, thank you very much for coming, and once again, my name is Todd, and Dawn Duellman is in the back, and she's the nurse that I have the privilege of working with, as well as the first assistant in the operating room, as well as the coordinator of events. So if any questions come up, please direct them to her or myself. That'd be great. So my background, I was born and raised just southwest here in Gelsville, so I did go to Get High. Don't hold it against me. My dad taught there for 30 plus years. I graduated from med school in Milwaukee, but before that I actually got a bachelor's degree in Spanish, which doesn't serve a lot of purpose here in central Wisconsin, but I went on to get a master's degree in physical therapy, so I have both sides of the equation as far as before surgery, after surgery, and in surgery, at least the perspective thereof. My orthopedic surgery training was down in Springfield, Illinois. I did 5 years down there from 2001 to 2006 before landing back home here in Wisconsin in 2006. So Wisconsin Rapids is my base clinic. That's where I have my standard clinic, but realize that we're here 3 to 5 days a month, sometimes 6 days a month, sometimes 7, just depends on what the issues are. So we are only a phone call away. If something does come up and you need to be seen, or there's questions or concerns, my family loves it if I come over, because then I'll potentially go down and see them down by La Crosse or on Alaska, what have you. So just because we don't have a physical presence home here doesn't mean you won't be taken care of in a very, very detailed way. You're only a phone call away, and the Black River Forest Drive is not that big of a deal for us. We do it all the time. But if we do have the privilege of seeing you, I see you at the Crone Clinic typically, just across the street. We do all of our own scheduling. The Crone Clinic does not schedule anything for you, so if you call our office, we'll get it all set up. When you leave our office, you'll have the appointment for us the next time, or when you leave the Crone Clinic. That way you're not having to deal with multiple persons. You really deal with us. You have our Wisconsin Rapids phone number. You call us and we'll get everything arranged, from x-rays to visits to surgery to all of those things. So just because, once again, we don't have a physical presence here doesn't mean that we won't take good care of you, and we're very detailed in that. So my background, I've been doing orthopedics, as Amy said, since 2006. I've been an educator and a proctor to other surgeons for years, since about 2010. I had the benefit when I first started practice of not being very busy. And when you're not very busy, you find a lot more time to read about different things. And I began doing a hip approach, which was called an anterior hip approach, but at that time, less than 2% of all surgeries in the country were done in that regard. I had time and I went down and visited a gentleman down in Texas as far as how to do that operation, came back to Wisconsin and began doing that in roughly 2008. 2010, somebody thought I had at least enough knowledge to teach it, and I've been teaching it since 2010 to different surgeons throughout the country. And actually, interestingly enough, surgeons from around the country come to Black River Hospital to learn how to do the surgery. So at times, well, you might have an operation, and whether it be a knee or a hip, typically a hip, and another surgeon's there from goodness knows where. They aren't doing the operation, they're simply observing. But to think that other surgeons come here to learn how to do hip replacement surgery or knee surgery is pretty neat. As far as the techniques of the hip, we're going to spend some time on that. But obviously the knee surgery, we do different things intraoperatively. The overall technique for knee replacement surgery is not that different than it was 10 years ago. But what we do intraoperatively makes the difference in the recovery, and we'll talk about those things. But basically the goal of the knee surgery is to make things more tolerable. Same with the hip surgery. If you need either one of those, it's already tough enough, and our job is to try and at least soften the blow, if you will. So that's me just teaching a course on hip replacements. So the courses that you get to teach are really interesting, because you go and there's 30 to 50 surgeons from all over the country, and we do a didactic session where we get to talk, and there's a lot of naysayers in the crowd, and most surgeons are pretty arrogant and want to get their opinion heard. So by the end of it, you're kind of at least changing their mindset and their thought. And then after the didactic session, in that picture, we get to work on cadavers. People who are generous enough to donate their body to science is used in laboratories, and each surgeon at the lab gets to work on a cadaver, and then myself or Dawn go around and proctor the surgeries so they can learn how to do it firsthand. And then it's up to them if they want to take that back to their facility and do such a thing. But when I first started, like I said, a very small number of surgeries were done the way we do them here, and now almost a quarter of all surgeries in the country are done through what we call an anterior approach for a hip replacement. So using the tagline, excellent always at Black River Hospital, you know, the plan for today is, you know, some background information regarding typically hip and knee pain, but you can use that same information to shoulders, wrists, ankles, things like that. But specialty surgery really needs specialty care. To put to somebody who's had a specialized surgery, a hip or a knee, or anything in that regard, and put them in a bed and treat them like a person who has pneumonia or a heart attack is wrong, and we've learned that over the years. And so we wanted to make your specialty care here truly special, and then using innovative techniques to give you the most or the best rehab potential you can have. And we're going to go through some of those things. So why specialized orthopedic care? We just mentioned that, but surgeons, nurses, assistants, the OR staff, and the therapists, they all have to be on the same page. If one person's out of line or one person doesn't have the same goal as everybody else, it makes it very difficult. Our goal is to get you up and get you moving as soon as possible. That second marker there says you're not sick. If you have a knee or a hip replacement, you're not sick. So we don't leave you stay in bed. You're up, you're moving right away. They know, the patients know what my expectations are of them, and hopefully they have significant expectations of me. But we treat you as a healthy person. So unless you're getting breakfast in bed from your spouse every day, that's not going to happen in the hospital. You're going to get up at the crack of dawn, you're going to be in the chair, you're going to walk, you're going to go to the restroom, you're going to be out of bed every time there's a meal, and walk the halls, things like that, as soon as possible. So that starts on the day of surgery. So we treat you like a healthy person. You dress in your own clothes so you feel comfortable. With that, we have been able to deliver better care, and we've truly made our satisfaction rate that much better here. Our outcomes are clearly better than national averages. This hospital is state-of-the-art. Impressively, you're already adding on again, which is impressive for a small community-owned hospital, and I challenge you to stay that way with the tides that are occurring in healthcare. To stay state-of-the-art, to stay community-owned is truly a gem, and until you go somewhere and are part of one of the other larger institutions, I don't know that you can really appreciate what you have here. I've been through 2 other different hospitals that I worked. Both were community hospitals, much like you have here. They're no longer community hospitals because of the ebb and flow of healthcare. And I guarantee you every person on that board and every person that works in those hospitals would give their left arm to go back to community hospital, because it's yours. And you guys get to dictate what happens here. So you don't need to specialize personal care. It's interesting, we always hear this on the radio. You're in a small town, specialized care, you don't need to go elsewhere. I've been elsewhere, and probably many of you have been elsewhere at other institutions. And you know, healthcare is a little bit like going, I always say, going to the supper club. It's always better if you go to the supper club one town over. For whatever reason, the supper club in your town isn't probably as good. The fish fry or the prime rib on Saturday just isn't quite as good, but it's really pretty damn good if you stay back and enjoy it. And so I don't think you need to go to a bigger institution, and I would challenge you that our numbers beat them in patient satisfaction, in complications, in overall care, walking, and post-operative outcomes. I know we're better than the national average as well as our regional competitors because I see the numbers. With specialization, we've been able to decrease our transfusion rate to almost 0. I don't remember the last time we've transfused somebody after a surgery. Increased our discharge to home rate to essentially everyone. And hospital complications, readmissions are darn near to the bottom. And then obviously what you all care about is patient satisfaction and long-term outcome. And those things have all improved through the specialization. So how do we accomplish such things? Well, obviously the same thing. It doesn't matter what business you're in. Teamwork, communication, state-of-the-art techniques, personalization, and constant evolution. The way we do it today is clearly not the way we did it 3 years ago, 5 years ago, or 7 or 8 years ago. We've learned along the way, and you have to at least have that ebb and flow. Learn from what you did and make changes accordingly. Personalization, that's the beauty of the small town care. I really believe that. Dawn, for every patient, has basically what you need to do, and it's personalized to you, from appointments to follow-up to what to do with the bandage to what to do with medications and those types of things. We want you to know as much as you possibly can. That way the questions don't come up when you're at home. So that's kind of the background. Now we talk a little bit about the nuts and bolts. You know, what is arthritis? And it's defined as inflammation of any joint. There's hundreds of or over 100 different types of arthritis. It affects a lot of people in America or in the U.S. every year. And there's two primary types. You've heard of rheumatoid and osteoarthritis. The vast majority of what we see these days that require surgical intervention is osteoarthritis. Rheumatoid arthritis, our rheumatology colleagues have done very well in treating rheumatoid diseases medically, so we don't see the joint destruction like we saw in years past. So we don't really see that as much. It's more osteoarthritic. On this image, this is a hip. Cartilage is normally nice, smooth, and white. It's got some cartilage destruction, and that's what arthritis is. It's basically the covering of the bone, the cartilage is starting to wear away. And it can be with a rheumatoid, your body's attacking itself. With osteoarthritis, that's just the wear and tear of life. So when do you talk about surgery? When do you consider joint replacement? I always often say I'll never tell you you need your hip or your knee replaced, or your shoulder, or whatever joint it is. You'll tell me. When the pain is significant enough that you can't do the things you want to do, when it's affecting your activities, where maybe your personality, your mood, whatnot is not what you would like it to be, and you can't do the things you want to do, and the conservative things have failed. When those things happen and you're saying, I'm willing to risk an operation to get rid of the pain that's affecting me on a daily basis. And when that's the case, a conversation with an orthopedic surgeon is probably a reasonable thing to discuss whether or not joint replacement would help you out. So what are the benefits? Why would you ever do a hip replacement? The number one on there is reduce or eliminate pain. That is the primary goal, that is the secondary goal, that is the third goal. But if you can eliminate the pain, you can enhance mobility. That one says hip, but obviously any pain that's joint related. You can improve the quality of life, return to normal activities, and hopefully you can return to low impact sports activities, whatever those are, whether it be hunting or pickleball or whatever you like to do. So your experience here at Black River, how do we do it? You know, basically everything begins with our clinic appointment. A phone call, a conversation, looking at x-rays, physical exam, a good medical history to see when it's bothering you, how it's bothering you, and what's really going on. If then you've failed those conservative things, then you go on to what's called the pre-op education. That's where we spend a great deal of time with you at the clinic visit, and then we talk about what you're going to expect. The day of surgery, anesthesia, in the hospital, and when you go home. So a great deal of your recovery is based on the education that you need to learn before, during, and after. A mentor of mine, it's not an official quote, but a mentor of mine, George Davies, who worked out of lacrosse, he said, if I do it for you today, I help you today, but if I teach you, I help you forever, which is true. Education is probably the key to this entire surgery, as well as probably the best prognostic factor for your outcomes. If you know what you're getting into, and you know what our expectations of you are, you'll probably have a really good outcome. So education comes from myself, but more so from Dawn, the clinic nurse and first assistant. She's pretty much the vital link for the information as far as answering questions, fielding concerns. You'll receive a informational binder that Dawn wrote that talks about what to expect before, during, and after. That binder is, there's two specific binders, one's for hips, one's for knees, just because they happen to be the most common things we see. But it talks about what to expect before, during, and after, and it's a great informational source for after surgery when you're sitting at home on a Wednesday trying to figure out, should your leg feel this way or should your knee or hip feel this way, and you call and she might just say, well, turn to page 42. It says exactly what you're talking about. So you're not alone when you're sitting at home trying to figure things out. But education clearly helps a great deal. So the day of surgery, anesthesia. What do we typically do if you do need an operation? Typically we do surgery under what's called spinal anesthesia or regional anesthesia. It numbs you from the waist down, and we'll go through the reasons why. But we use different techniques for pain relief. We give you medications before surgery that help control the pain afterwards. We do different types of injections in the operating room. Those are the things that I said you probably don't see or know with regard to a knee replacement surgery or hip surgery, but the techniques that we use are meant to help the pain afterwards. And then post-operative ice is everyone's friend. So for pain relief, what do we do before surgery? We give you medications like Celebrex, which is an anti-inflammatory, which helps with pain, but it also helps with other things with regard to hip surgeries. And then we give you a long-acting pain medication typically, if you can take that. The research shows that if we stop the pain receptors before surgery or before any stimuli, we're going to control the pain better afterwards. And so we like to hit it early. Our regional anesthesia means spinal anesthesia. We numb you from the waist down. That's scary for some people, but you're also asleep. You're basically like a colonoscopy. You're kind of in a la-la state. You aren't really aware of what's going on around you, but your legs are numbed from the waist down. And once that spinal wears off, we get you up and get you walking. So why would we do that? Why would we numb you from the waist down and not just have you go to sleep? These are the reasons and the rationale. All very good ones. Your pain is less. Your chance of a blood clot is less. There's less blood loss in surgery, meaning so your chance of a transfusion is less. Decreased pain medication needs. And if you don't have to take the pain medications, you're less likely to vomit. If you're less likely to vomit, you're going to participate in therapy. You're going to be happier. And you're going to have a better outcome. So some people want to go to sleep, and that's fine. It's your body. I'm not going to tell you what to do. But realize that those are very good reasons to undergo a spinal versus a general anesthesia. As far as injections during surgery, we inject what's called a long-acting pain medication, or Novocaine. You've all had probably to your dentist appointment and used Novocaine on a tooth. We use a medication that's much like that. Nobody uses Novocaine anymore, but it's much like that, but it numbs up the area for roughly 3 days. So if you can imagine going to the dentist and getting your tooth numbed up for 3 days, first off, it'd be tough to drink anything for a couple days, but same thing is on the inside of your knee. So we inject that throughout the knee after surgery to make things more tolerable. There is no such thing as a pain-free surgery, right? I mean, we say it not really tongue-in-cheek, but truthfully, the only pain-free person, unfortunately, is an expired or a dead one. We all have different aches and pains at times, and surgery is going to make it worse. We're just trying to make it more tolerable so that you can participate in rehab. So once again, we treat you like you're well. You're not sick. You're out of bed for meals. You're walking the day of surgery. You dress in your own clothes. And the vast majority of everybody does go home the next day. So these surgeries are typically planned 4 to 6 weeks out, if not longer. And so that should give everybody ample time to talk to a friend, a neighbor, a family member, if you would need any help at home. And we go through that as well. So innovative surgery takes commitment from everybody. Once again, the patient, the therapist, the hospital, the nurses, the anesthesia providers, we all need to be on the same page. This is just a picture of a couple different joints. The joint on your far left is a shoulder replacement. It's got a metal ball with an artificial joint here. We do those, obviously. This is a knee replacement. That's an arthritic knee with metal and plastic. And then this is a hip replacement, and we'll show pictures of that as well, with a metal ball and a cup. Those are all surgeries that we do commonly here. So anatomy of a hip, we showed the ball of a hip earlier that had erosions on it and had the cartilage that was worn out. This is a normal hip. But what are the symptoms of hip arthritis? The number one symptom that we hear about is groin pain. Hurts in the groin. People will say it's a muscle pull or something happened, maybe they feel like it's a hernia, but it's typically groin pain. People will say it's difficult to lift their leg into the vehicle, they can't put on their own socks anymore, things of that sort. Stiffness, immobility, deformity not so much, but more of a limp. These patients typically with a hip problem will have that waddle where they kind of throw themselves to one side. They've got both hips bad, they'll throw themselves back and forth to both sides. But it truly is a limp, or a lurch might be a better way. That image shows just the degenerative changes of the hip joint itself. It's kind of red and inflamed, if you can appreciate that on the image. Here are some x-rays of an arthritic hip. So if you look at that hip on your left, you see a nice space between the ball and the socket. If you look at this one, there is no space between the ball and the socket. The socket is the round ring that goes around. The ball is here. There's no space up top, whereas if you look at the space on this one, there's an excellent space between the ball and the socket. There's no way to put cartilage back in there. That's the loss of cartilage. The erosions you saw on the x-ray or on the cartoon image slides ago, there's no way to put cartilage back in there. You can't jack it up, you can't put in a Zerk fitting, you can't do anything like that. It just doesn't work. Stuff like that's been tried and it fails. So the treatment for that is conservative things like we talked about, activity modifications, medications, the Aleve, the ibuprofens, the Motrins of the world, weight loss. Some people will use a cane, those types of things, but sometimes those things don't work or they're not palatable. They aren't going to be something that you can do day in and day out. So there's no good option to salvage that. And so what's a hip replacement? Well, that's this. A hip replacement takes out that ball that you see in this image, and we basically cut this ball off and it goes away. And then we put in a piece of metal that goes down inside the thigh bone. And this is a real one up here, but that's what goes in. It's essentially a wedge. On top of that wedge, we just put a ball, and the balls come in different sizes, as you can imagine. And then if I just had this rub on the bone, it can actually start to wear a hole in the bone. So what we do is we put in a cup as well, and that cup is metal. And then in between the cup and the ball, we put a piece of plastic. If you stay up late at night and listen to the metal on metal or the attorney commercials that say, have you had your hip replaced, was it metal on metal? Instead of a plastic liner in the middle, that was metal. Didn't work the way we had hoped, obviously. And the liners that we use here are typically plastic on the inside. The ball is almost always metal. That ball is pink. That's a ceramic ball. We use that for persons that might have a nickel allergy and who can't have stainless steel. The metal parts of the hip here and there are made of titanium, and they all have a rough surface on them. We don't cement them in. Your body actually grows onto them, crazy enough. So if I pound this in to your thigh bone, and you can kind of appreciate it here, there's a rough surface. Your body thinks that's bone and grows right onto it. And after 6 weeks, you'll need a chisel to try and get the thing out because it is grown in that solid. Same with on the cup side. It's got a rough backing. It does have spots for screw holes, so if you want to put a screw hole in, we typically do, because if somebody fell in the first couple weeks, we don't want that cup to lodge loose or dislodge loose. So that's a hip replacement. We do that from the front. Couple 2-inch incision, 3-inch incision, depends on the person. So how long does it last is a common question. Well, we hope to goodness more than 20 years. The older data would talked about 15 to 20 year data. We use specialized plastic that I'll show in a little bit. But this metal on plastic has been proven through the test of time of hip replacements that it gives you the safest track record, and it allows a lot of options for myself in the operating room to adjust leg lengths and restore your anatomy the way it should be, or the way it was before it became arthritic. So here's another one of those innovative things that you probably wouldn't see or appreciate, but we use a different type of plastic in your hip. This has got, it's almost a pink hue or a pink color to it. It's basically impregnated with vitamin E. What does that mean? Well, a standard piece of plastic degenerates with time. It's a brake pad. You rub it enough, it's a brake pad. It's going to keep rubbing, it's going to wear away. Well, one of the reasons that that brake pad or that piece of plastic inside there wears away is because of free radicals. Free radicals are basically everywhere, but in plastic, as the ball rubs on it, those free radicals eat away the plastic and the shavings go somewhere in your body around the hip joint. They figured out long ago that, not long ago, 12 years ago, that if you take that piece of plastic and impregnate it with vitamin E, the vitamin E scavenges the free radicals, so it doesn't let them go. So that plastic now piece will hopefully last 25 plus years. So instead of the fear, years ago, you didn't want to replace a hip on somebody that was young because it was going to wear out. That's true to a degree, but clearly not the same fear as it was 15 years ago, because that piece of plastic is going to last a lot longer in all of us. And so that's what we use on all of our hip patients here, because I don't, whether you're 90 or 50, I have no idea how long you're going to make it, so I'm not going to be the one deciding that you get a cheap piece of plastic here that's going to last 10 years versus the kind of the pimped out version that will last 25 years. I don't make that decision. So we use the same on everybody, regardless of age. So there's multiple ways to replace the hip. The posterior approach has been the traditional way. When we say approach, that's basically how do you get to the ball in the socket? Where do you make the incision? So there's multiple ways. I always use this example. There's a lot of ways to get to Walmart. I can tell you all how to get to Walmart and tell you all a different direction, but you all will end up at Walmart. So the end result's the same. I don't care how you get to the hip. The goal is pain relief in the end at 3 months and 6 months and 1 year and 20 years down the road. But clearly, if I tell you to get to Walmart and you got to head up, and you're going to Walmart here in town, you got to head up through Eau Claire and back down along the River Road, clearly there's a risk of collateral damage, number one, and you're going to burn a lot more energy. So these approaches, the posterior, the traditional mini posterior, or the anterior lateral, are a little bit more indirect. The anterior actually has a word in front of it called direct anterior, because it truly is directly at the hip. The hip ball itself actually points to the front of our pelvis. It doesn't point posterior. Posterior means back. So to go posterior, you actually had to work around the corner. There's a lot of reasons why that became what it is, but that's the way it was taught for years in residency programs. And obviously, if you teach it that way in residency programs, everybody who comes out, that's the way they do it. And it takes a lot to change a surgeon's opinion or change a surgeon's way of doing something. I think every surgeon believes, and they better believe, that they're doing it the best way they possibly can for the best outcome of their patient. So how do you get somebody to change that is a very difficult proposition. So there's multiple ways to skin the cat. The direct anterior has benefits that I think merit at least the looking at it. So the posterior approach would be kind of the, I say old, but it's still used. It's an incision on the side of the hip that kind of curves to the buttock. Very well. You can do that. Mini is making it smaller as well. Well, what's good and bad about it? Well, it's comfortable for the surgeon. We all train that way. At some point during our training, we made those larger incisions so we could see everything. There's great long-term data. We know it does okay. We know it does very well. More than okay, it does very well. So why change it? Well, these are a couple things where the reasons why I thought would be a good idea to change, and not just myself, but a lot of the other persons who have changed. Leg lengths. One of the complications of a hip replacement is not having the legs exactly the same length. It probably doesn't really matter that much if your legs are off a little bit. As a matter of fact, most of us in this room, our legs aren't the same length, by the way. I always say there's no such thing as a perfect Scotch pine Christmas tree. They're all, limbs are a different length, and same is true for our bodies. But leg lengths, we try and match them up really close, because number one, it saves me a lot of time in the clinic of having the leg length talk. Number two is with an anterior approach, Dawn will measure your legs multiple times in the operating room on the table. And so I think I'm a much better leg length surgeon than I was before. Hip precautions. This one drives Dawn and I crazy. Hip precautions are not necessary after an anterior approach. When I say that, the traditional posterior approach, you were told you couldn't cross your legs, you were told you couldn't sit in low chairs or rotate your leg out. With an anterior approach, those things don't hold true, because an anterior approach, the benefit of an anterior approach is, and we're going to go through it, is you don't cut any of those tendons or muscles that would predispose you to what's called a hip dislocation. So a posterior approach is good, it works, but there's probably a better mousetrap out there. And so that's where the change came in. So this is a direct anterior approach. Shows an incision with the patient lying on their back in front of the hip. Now your incision would be much, much smaller than that, but for the cartoon version there, they're just showing where the incision would go. So these are the advantages as a patient. So there's going to be advantages for the patient and advantages for the surgeon, vice versa. So less pain typically leads to a quicker recovery. If you don't need to cut as many things, you're probably going to recover faster. No pillow between the legs after surgery. So in a posterior approach, typically there would be a triangle or a wedge pillow between your knees, and that's the way you would lie or sleep for 6 weeks or sit in a chair. That's gone, so that uncomfortable portion of the wedge pillow is no longer there. Decreased length of hospital stay. If your recovery is faster, you don't hurt as much, you can get up and move sooner. So that's held true. Minimal postoperative need for therapy really we don't send anyone to therapy after surgery, after hip replacement surgery. The therapist will see you while you're in the hospital to make sure you can get up, get to the restroom, make food, go, visit with people. But after that, after their 1 or 2 visits with the therapist to make sure you can get around, you won't see them again because it's unnecessary. No restrictions on movement. Once again, those hip precautions aren't there. You can bend, twist, stoop, ride four-wheeler, horse, whatever it is you want to do. The goal of surgery is never to take anything away. The goal of surgery is to allow you to be the person you want to be and do the things you want to do. And then we mentioned the last one, better leg length control and less dislocation risk. We mentioned it briefly, but one of the complications of every hip replacement is the ball. So your hip is ball and socket. One of the complications can be is the ball could actually pop out of the socket. From an anterior approach, from the way we do it here, the chance of that happening is only 0.6%. Not very common at all. From a posterior approach, that risk is much higher, and for that reason is why they tell you don't cross your legs or bend more than 90 degrees at the waist, those things. And with an anterior approach, we don't have those restrictions because the chance of dislocation is so low. So those are advantages for you all as the patient. Well, no muscles are cut. These are now advantages basically for me. No muscles are cut. Excellent visibility. Already the hip actually points to the front. Why make an incision in the back and work around the corner when you can go straight at it from the front and you're staring right at the joint? Leg length determination, reduced dislocation risk. This is great. These are x-rays taken in the operating room as the surgery is going on. Amazingly, from a posterior approach, that's not as easy to do. It's actually quite difficult to do. So before we pound in this cup and put a screw in, we know exactly where it is by looking at the x-ray. So there are no surprises later when you get your x-ray in clinic or anywhere else for that matter. So you're more likely to get everything exactly in the position it needs to be. And there's multiple articles that point that out as well. Obesity is less of a factor. We all have a lot more meat on the backside than we do in the front of our thigh. That's absolute. And so I would challenge the surgeon who goes posterior that doing an anterior approach is much easier on the obese person, the average obese person. And if all those things hold true, clearly happier patients and selfishly, I do enjoy that. Unique risks. So obviously, you can't have all those benefits without having a downside, right? It doesn't matter what you do in life. And the biggest thing is there's a learning curve. Obviously, if you've never done something before in your life and you start doing it tomorrow, you're probably going to have trials and tribulations along the way. So the learning curve is real. They talk about that it takes probably 20 surgeries to decrease your complication rate. Multiple articles are written about that. And obviously, the more classes you go to, courses you go to, lectures you go to, that number improves. We've done well in the thousands of these, so I think we've at least made it through, well, I know we've made it through multiple of those learning curves. I don't do a posterior approach ever. I haven't in 10 years. So if somebody came to me and said, hey, I want the traditional surgery with the incision on the side or the buttock, I would direct them to someone else, because if I haven't done it, it's not fair for me to do that for the first time on that person if there's somebody 20 miles away that will do that. So there is a learning curve. We've been through that, and I don't think that's an issue for us anymore here at Black River. Complications. These are complications with whether you go posterior, anterior, name the surgery in orthopedics, and these are essentially the complications. Infection is the one that scares us the most. If bacteria get on this metal, we can't get them off, and the bacteria have to come out. Interestingly, though, in a small community hospital that does multiple joints, 75 to 100, the complication rate is lower than a lot of larger institutions. You have a huge benefit of being in a small town, and this is not proven. I can't give you the literature, but here's my thought process as to why that is. The sick patients, those patients that are really sick, pneumonias, infections in their leg and those things, we don't typically keep them here, right? We can't. We don't have an intensive care unit at our community hospital. So we don't have that same amount of bacterial load in the hospital or in the operating rooms and things like that. So That being said, typically we can help the infection rate and decrease that. We also do a lot of things to help prevent infection, but that's a real complication. Less than 1% at this institution, by far, way less than 1%. Blood clots are a risk. Implants can break, very rare at this stage. Malalignment, it could be put in wrong. That's an error on my part. Premature wear, we don't usually see that. That's usually corresponds if we put it in at the wrong angle. And cardiovascular compromise, nerves can be injured, arteries can be injured. In total, though, those things for all comers are much, much less than 2% if you added those all up. So I always quote 95+% of the time there's good to excellent results, and those things aren't an issue, but yet we obviously talk about them because they're the things that scare the crap out of us. So just briefly, we'll touch on knees. This is just a picture of a knee. Much like the other cartoon, just shows the smooth white covering of a knee, and then you see where it's kind of eaten away. It's not really eaten away in wear and tear arthritis, it's just rubbed itself raw. The cartilage is worn off. If you compare that to the laminate on your kitchen floor, you could walk across your kitchen floor every day. And someday you're going to walk past and go, huh, the subfloor is coming through. And your spouse might say, well, it can't be coming through. It wasn't coming through yesterday. Well, that's the same as arthritis. I have this conversation with people almost every day. Somebody will say, it can't be arthritis. I did not hurt yesterday. Well, it just hadn't got to that point where it wore through all the way yet. Nobody ever talks to their cancer doctor and said, cancer yesterday. Well, yeah, you did. It just wasn't apparent. And same with arthritis. It can come on quickly. It can come on gradually. It can hurt some days and feel fine other days. It'll drive you crazy if you try and figure that portion of it out. So that's what an arthritic knee looks like in the cartoon version. Basic anatomy. You know, you've got ligaments and you've got cartilage inside the knee. Most, and we'll talk about the knee surgeries, but all total knee surgeries cut the anterior cruciate ligament at this stage. For a while there, we did knee surgeries where we did not cut the ACL about 4 or 5 years ago. That's kind of fallen out of favor again. It goes in ebbs and flows. But the interesting part is for most persons who have their knee replaced, the ACL is not working very well anyway. And so every knee replacement right now, not every, 99+% of knee replacements at this stage that are total knee replacements will get rid of the ACL. There's another way to make so your knee is stable without that. So here's a partial knee replacement. So this person has arthritis, really no joint space on the inside part of their knee. They have a nice space here on the outside and no real arthritis to speak of on the outside. So the concept was, well, why would we replace this side and that side if that side's still good? So partial knee replacements has been around for a long, long time, and this is a model of a partial. And it's tough to see obviously back there, but what this is the ACL and the PCL, the two ligaments in the center of the knee, are saved. So if you only have to replace a part of the knee, you leave the ligaments in the center. And actually you have to have the ligaments in the center, otherwise this surgery won't work. And so what happens is you put in metal and a piece of plastic between. So that way when you walk, it's metal rubbing on plastic, much like a hip, metal rubbing on plastic, but only the diseased part of your knee is taken care of. That's the inside half. In the US, it's only approved for the inside half at this point. So if you have arthritis only on the outside half, which is very rare, there is no medical device that's approved right now for a partial knee of just the outside half. FDA approved, I should say. So that's a partial knee. That's what it looks like outside the body right there, and it's basically just a sliding component. So this is a total knee. A total knee replaces the inside and the outside. And so what happens at that point is, I don't know if you can see inside of this one, there's a post, a white post sticking up. So if you take out the cruciate ligaments, you substitute something in their way, and this happens to be a piece of plastic that acts as a post that acts as the ACL and the PCL. So you might sacrifice them, but yet you're substituting something else. We call it basically ACL, PCL sacrificing knee versus a PCL sparing knee. Either way, this is what it is. It's two pieces of metal and a piece of plastic. That piece of plastic is held in with a cotter pin. So if you wear this thing out in 20 years, you don't have to do anything to the metal you put in. You basically kick out the cotter pin and put a new piece of brake pad or a new piece of plastic in. So you don't cut off the leg and cut off the leg contrary to belief. You shape the bone into this shape. And that's where you leave the ligaments on the inside and the outside of the knee. And then you put a cap or a crown, much like a tooth cap or crown. You put that over the edge of the bone, and then you do the same thing on top of your tibia, and you cement those in. Unlike the hip where we said they grew in, this is actually cemented in, and roughly 9 minutes after we put it in, you would need a chisel to get it out because that cement hardens that fast. And so you will always have a click in your knee afterwards. It's metal hitting plastic. It's got to make a noise. Obviously it's muffled with skin and fat, but you'll feel that inside the body. But it works very well. Once again, the goal is pain relief, but it takes a lot of work to get there. This surgery is 90% what the patient does and 10% what we do. I'll say that again. The hip is a lot what we do, heart surgery is a lot what we do, but a knee replacement is 90% on the patient. If you don't bust your hump and work hard in therapy and work hard at home, you will have a suboptimal or poor outcome. And it really makes for a hard conversation at 2 weeks and 6 weeks. So we really, really stress doing your therapy and doing your exercises afterwards. We've only had one patient ever come to clinic and say, I just don't think I'm going to do the exercises. Well, that person clearly we didn't operate on, and he knew it, and he was the first guy to tell you he was lazy and he wasn't going to do anything, and we sent him out. The hard part is the rest of us say, yes, we're going to do it, we're going to work hard, but once you are in pain, once you're constipated, once your leg is swollen, once you feel basically like blah because of the pain pills, it's really hard to grab that fortitude and do your exercises. But those are the most important days that you have to. And I'm not trying to, scare you, but it really is. If you can get your motion back in the first 2 to 4 weeks, you will have a good outcome. Clearly, the best predictor of outcome is being able to get it straight, getting able to bend, and do it well. And if you can do those things in the first 4 to 6 weeks, I'm confident that 6 months, 6 years, 10 years down the road, you're going to be doing well. So, motion therapy, therapy, therapy. So that's just kind of the nutshell of knees. Shoulders are really close to the same. There is a lot of therapy involved in shoulders, but obviously we don't walk on our arms. So as far as you'll do 100 knees, 70 hips, and 5 shoulders. Just because we don't walk on our arms. So I don't have as many slides. I don't have slides for shoulders, but it's pretty rare that we do a lot of shoulders. Now we've done one every month, I think, now for the past couple months, but it's not quite as big. So I truly believe here at Black River you are going to get a commitment to excellence. You're going to get the same team. You're going to get Dawn and I no matter what. You get the same OR crew that have done this now. I've been here since 2011 for 7 years. So they know the way we like to do it. They may not always like the way we like to do it, but they've been very accepting and we have great outcomes. It is not the same old community hospital. Clearly it is state of the art. The stuff we're doing here is the same, if not better than what we do in Rapids, in Wisconsin Rapids, I should say. And I can compare us to the Marshfield clinics, and I can compare us to the Gundersons, and I can compare us to UW-Madison, and I will hold our data up or our outcomes up to theirs any day of the week and argue that we do it better. Because we are better on numbers and stats. So I'm not really sure why somebody would travel out of town short of family members and those things when we can actually do it better here. So.